Hello everybody, good evening. I hope you're enjoying the evening so far. I'm delighted to be able to join you and have a discussion around the sports medicine doctor role in managing low back pain. My name is Dr. Matt Cosgrave, or Matthew. And by way of introduction, a little bit of my background is that I studied in Belfast in Queen's University. I trained originally as a GP, working through a variety of specialties in the NHS. And then I moved down to Dublin to pursue a career in sport and exercise medicine and did my specialty training in Dublin. Outside of working in the clinic here at Santry, I work with a number of sports teams, but over the last 3 or 4 years, I've had the pleasure of mainly working with the Irish women's national rugby team, and over the last couple of years with Connacht Rugby men's seniors team. So, from a point of view of what I hope for you to get out of my talk today is really to answer these 3 questions. Do I need to see a sports medicine physician? Do I need an MRI? And do I need an injection? Before we get into things, I'd just like to reassure you all that when we talk to patients, these are the 3 most common emotions that they present with in relation to low back pain. Worry over some sort of underlying disease process or pathology that maybe they're missing, confusion over often why their pain isn't getting better or why their pain comes and goes unpredictably, or apathy, which is really down to a lack of motivation around managing their pain, in that no matter what they seem to do, they're always suffering. Interestingly enough, these 3 same emotions are often what physicians, physiotherapists, general practitioners experience with low back pain, because it can be a tricky subject, but hopefully I'll try and uncover some of the hidden truths behind that today. Do I need a sports medicine physician? I don't think we help ourselves by calling ourselves sports medicine physicians. Really, this is a common misconception that the only people that we treat are people who do sport or athletes. Really, we are musculoskeletal physicians. So yes, we do look after teams, yes, we do look after athletes, but we really look after any active individual, which from a point of view of day to day, that's really the general public. And the vast majority of the patients that we see in clinic here are general public and are not high-flying athletes in any shape or form. About 80% of people at some stage in their life will experience low back pain. And interestingly, about 80% of these cases will improve on their own or with very little treatment within about 6 weeks. My role really comes into it whenever we have this huge chunk of 20% who are not improving over the 6 weeks to 3 month period, which can be a substantial number when you crunch when you break it all down. Really, what the sports medicine physician does is considers, do we need to order other investigations? Now, this may be a scan of some description, a CT, an MRI, or it may be some blood tests. Really, the main role for us is to confirm a diagnosis. Often, once we have the diagnosis, actually managing the problem can be quite straightforward. Sometimes when we're in the dark about the diagnosis, we try and we almost have a trial and error process, but if we can confirm a diagnosis, it's often fairly straightforward to get on a plan to recovery. Excluding severe pathology is a big part of this, and this falls into the worry side of things for patients. A big concern that patients often have is there some sort of underlying disease process such as cancer? And that is extremely rare when it comes to low back pain. But nonetheless, when back pain has been going on for a long time, it's always something that we have in the back of our mind, and it's always something that we make sure we exclude. We'll also review the treatment plan that the physiotherapist or the GP has already put in place, and we'll see, can we add to that? We rarely change things significantly, but we'll make small adjustments. And then finally, we think about treatment adjuncts. So rehab is a huge part of what we do here in the clinic, but there's always options for some additional help. And often for us, that falls in the way of injection therapy, which I'll discuss for you in a little bit further detail later. So do I need an MRI? The simple answer is no, not everybody needs an MRI, and the vast majority of patients who have low back pain don't require an MRI. This is a really great graphic that explains why we don't all need MRIs. These are findings on individuals who are asymptomatic. So people with no back pain have a variety of changes, and the percentage of patients who have changes increases with age. Just for one example, disc degeneration in this top area, which is often reported on scans and often causes concern for patients. Nearly 100% of patients in their 80s will have disc degeneration. But even more interesting, at the age of 30, 1 in every 2 patients will have some degree of disc degeneration on their scan, even if they're totally asymptomatic. So a scan is not always necessary. So when is a scan necessary? And this is what we use scans for. This is what the sports medicine physician is really looking for. If we go clockwise from the top left, this is a condition called sacroiliitis. This is an inflammatory process where you get some inflammation in the base of the lumbar spine, where the sacrum, which is a little triangular bone, fits into the pelvis. The reason we look for sacroiliitis is it doesn't normally respond to conventional treatment. Usually it's caused by some inflammatory process in the bloods, and therefore we often need to give medication to reduce that inflammation in the blood, which will then reduce the inflammation in the joint. This is not very common, but when it does present, it tends to be in the younger patient. If we move over to the right then, we have this condition called facet irritation. This is a lumbar spine from the side. The square blocks on the left are the vertebral bodies, and they sit on top of intervertebral discs. The vertebrae then communicate with each other in the back through something called a facet joint. Now, this facet joint, like any joint in the body, a knee, a hip, they can become irritated and inflamed. So when we look at MRI scans of backs for patients who are not improving, really we're often looking to see, are there any individual joints that are irritated or inflamed that could be contributing to symptoms? And therefore, is there a target for some injection therapy? In the bottom left, this is the view of a spine in cross section. So this is like I've taken you, lay you down, and then chopped you along, and I'm looking down the body. This pointy bit at the back is called a spinous process, and this is the area that we feel when we feel down the back. In patients, again, usually young patients who are very active and who do sports that involve a lot of bending of the back, so gymnastics, tennis, there is a risk of developing something called a pars fracture or a stress fracture. So in the younger patient especially, this is always something that we want to exclude. Finally, which you're probably most familiar with when it comes to low back pain, is this condition in the bottom right. This is called disc degeneration. The black circle in the center is the spinal cord. The yellow marks to either side are the nerve roots. When you get a disc bulge or a disc protrusion, what happens is the center of the disc, which is a jelly-like material, pushes out a little bit, and it causes the disc to bulge. The disc itself doesn't move, it just creates a little bit of a bulging on the outside edge. Now, this bulge can do a few things. One is it can create irritation around the nerve, and the other is, if it's bad enough, it can put some pressure on the nerve. And then if we think about treating this, often what we think about doing is delivering some sort of injection therapy, usually a steroid, in and around this area to reduce inflammation and irritation and to reduce any pressure that's on the nerve itself. So these are the 4 main reasons why we do MRI scans, but we know specifically what we're looking for. We're not doing the scan and hoping that it gives us the answer. We're doing the scan because we think that we already know the answer, and we're trying to confirm or exclude that. Excuse me. So from a disc point of view, I just wanted to give you a little bit more detail. So from a disc bulge point of view, the reason this is important, this is a spine on the left from the side. This is a spine on the right from the front. These gray areas that are running down the side and then are coming out on either side on the image on the right, these are nerve roots. Your nerve roots supply your sensation and your power to different levels along your lower legs. So when you come into us with symptoms, what we do is we try to correlate whereabouts on the leg, front or back, your symptoms are, and then when we do your MRI scan, we try to look at the disc at that level to see if it's causing some pressure around the nerve root. In many cases, you will have disc bulging that doesn't relate to your symptoms. So you may have disc bulging at this L1, L2 level, but your symptoms may be coming from L5 or L4. For that reason, MRIs are not useful in that they can create confusion for patients and sometimes for physicians as well, because we see disc bulging, but it doesn't marry up with what's going on in the history. Finally, I want to make a quick note on something which Katie has probably already discussed, which is a degree of fatty infiltration in the low back. When we are less active, we see a change from the left-hand side where the muscles are nice and grey, kind of like a fillet steak, to on the far right-hand side when the muscles are not being used because other areas of the back are having to work harder, for example, the facet joints. Then the back becomes weaker and we see this fatty infiltration. If we see this on a scan, it's a very good indicator to us that you'll respond well to rehab. So in summary, from an MRI point of view, we're looking to exclude significant disease. We're trying to correlate what we see and what you tell us with what we find on the image or on the MRI scan. It's really not guesswork, and we're not asking for the MRI to give us the answer. Finally, then, we're looking essentially, is there an area for injection? So if we see a disc bulge or if we see a facet joint that's irritated and it fits with where you're sore and where we examine you, then that's usually a good target for us to inject. The injection is only part of the treatment plan, however, which I'll discuss. And that brings us on nicely. Do I need the injection? Injections are not always straightforward, and often patients are a bit apprehensive about them. I break our injection treatments up into two major areas. One is for nerve root impingement. So if we have this disc pathology, or there are other causes of nerve root impingement, but if we have nerve root impingement, we've got two options. We've got a caudal epidural injection, or we've got a more sophisticated CT-guided nerve root injection. Again, we're correlating our MRI findings based on where your symptoms are, and we're deciding on what level do you need the injection. Sometimes it's not always clear exactly which level. Sometimes you might have a disc bulge at a couple of levels, and sometimes you might have symptoms that correlate with a couple of levels. When that's the case, we'll often do a caudal epidural injection. This injection is done right down at the base of the spine. We inject some steroid and it flows up along and around the nerve roots, and it bathes the nerve roots at those lower levels in steroid, and it reduces any inflammatory or irritant change around there. It's a little bit of a broad brush stroke, and we're hoping to tackle a number of different areas in one go. The CT-guided nerve root injection, however, is much more selective. We do that when we are very confident that the image that we see on MRI fits perfectly with the way the patient comes in. Now, this is not always the case, but when we have this sort of scenario, you get much more relief from a selective nerve root injection than by doing the broad brush stroke of what we describe as a caudal epidural injection. Technically, the caudal epidural is slightly easier than the CT-guided nerve root. We perform the caudal epidural injections in the clinic here as sports medicine physicians. We do this under ultrasound scan. The selective nerve roots, however, we have to refer to our radiology colleagues in the main hospital for this, because it's slightly more sophisticated, and we want to be exactly and precise about where we're placing that steroid. The next group of injections then is for the joints. I mentioned to you earlier about this condition, sacroiliitis, or inflammation around your sacrum. Again, normally the way that we treat this is with some medication to reduce inflammation in the bloods, but on occasion, if you just have it on one side, it can be because the joint is irritated, without inflammation in the blood. In that case, a steroid injection over that area can be very helpful. Again, we do this in the clinic here, and we do it using an ultrasound scanner to guide where we place the needle. Finally then is the facet joint injection, the joint between the different levels of vertebrae. Same principle, like a knee joint, like a hip joint. If it gets inflamed, they often respond very well to corticosteroid. It's not the mainstay of treatment, it's an adjunct. So we try to improve your symptoms a little so that you can then progress on and do whatever rehab is necessary. So are injections necessary? Not always, but we use them when patients are not improving or deteriorating in some shape or form. We only do them if the symptoms that you're telling us or the findings that we have on examination match up with what we see on the MRI scan. If they don't match, there's something else going on, and it's rare that that's the case. Finally, we do them if your symptoms are stopping you from doing good rehab. If you're too sore to rehab and we have a focus for injection, these can be extremely helpful in trying to get you some pain relief so that you can do the strength work that helps to take the pressure off the back, that helps to get you moving more naturally, get you feeling more comfortable, and then get you back to living a healthy and happy life. So how do you access us? Very straightforward. Self-referral, GP referral, or physio referral. And where? You can forward an email or a referral to sportsmedicine@sportssurgeryclinic.com, or you can give us a call on this number and you can have a discussion with one of the staff on the desk and they'll give you more direction about how to get in contact with us. I hope you found that helpful. There's a lot of information in there. You don't need to take it all away. It's really just to give you a flavour of what we do here in the clinic and how our role as sports medicine physicians help to supplement the work that our very successful and very proficient strength and conditioning and physiotherapy and rehab teams do here in the clinic. Thank you very much.
Matt, thanks for a great talk. We're going to start with some of these questions now. So the first one is from Tanya. She's asking, what advice can you give for the L4-5 disc tear with lumbospondylosis other than pain management?
So I suppose to a degree it depends on what the symptoms are. If there are what we describe as radicular symptoms, so symptoms that are not in the low back, traveling down the leg, then we have the option for some injections. If we have a good idea where the pain is traveling to and it correlates well with the MRI findings, then we could do a selective nerve root block. If it's a little bit broader or a little bit more difficult to ascertain exactly where the pain is radiating to, or if there's a little bit of discrepancy between what we're seeing in the patient and what we're seeing on the scan, then something like a caudal epidural would be a good option. So that might give some symptom relief, and then we would always do some follow-up rehab work, and that would be along the lines of the stuff that Katie discussed. Yeah. Strengthening of the low back, strengthening of what we describe as the posterior chain, which is the bum muscles, the hamstrings, the calf, and just trying to get the patient to move more comfortably and confidently.
Lovely, thank you. So, question from Margaret here. Is Botox successful in managing muscular spasms caused primarily by spinal fractures?
So, Botox we would use in a very select group of patients. Usually patients who have some form of muscular spasm or contracture. So these tend to be limited to patients who have an underlying neurological condition like cerebral palsy, or somebody who has maybe a long-term contracture following a stroke. It's not something that we use in the clinic to treat back spasm. Botox has a very broad effect on the system, so we can't target it to any specific muscle, and for that reason we're very selective about the patient group that we use, and we don't use it for back spasm treatment.
Okay, lovely, thank you. Question from John. Can a protruding disc in the lumbar region be the cause of constant knee pain?
It certainly can. If the lumbar disc prolapse is pressing on the nerve root that supplies sensation over the knee, then yes, it can be the cause. And often that is a case of patients who we see who have maybe had a long-term knee complaint for a number of years. When we see them, we assess their knee, we scan their knee, we maybe don't find much, and we get a little bit more in depth into the history. We find that actually they have some underlying back condition or back complaint, and we scan their back, and we'll find a disc or a nerve root compression that's actually the main source of their knee pain. So in short, yes, that can be the case.
Yeah. Anna's asking, how could she get sciatica pain to improve?
So it's a multifactorial approach, I suppose. Again, it comes back to what are the exact symptoms of the sciatica. What does the patient look like? What are the imaging findings? Do we have an option for injection therapy? If we do have an option for injection therapy, is it a selective nerve root injection or is it a caudal epidural injection? And then following that, can we get the patient comfortable enough to start to do some rehabilitation? And quite often, the sciatica pain will resolve on its own. If it's very refractive, then we do have oral medication options. We have injection options, and then we have some of the rehabilitation stuff that, again, Katie discussed, that is often the next step to get patients over the line and back to full fitness.
Okay, lovely, thank you. What treatment exercise do you recommend for multi-level lateral stenosis?
So multi-level lateral stenosis, again, is quite a complex but broad diagnosis. A lot of it really depends on what the symptoms are. So the mainstay is going to be getting the patient strong and getting the patient comfortable and confident moving again. If they have some specific pain target or pain level in, from that, when we describe multi-level spinal stenosis, we're wondering, is there an individual level in the spinal column that's causing one problem more than the other? If there is, we have an option for a selective nerve root block again. If the pain is coming from multiple levels and we've tried oral analgesia, we've given it time and it's not settling, then a caudal epidural might be an option to give a little bit of a broad cover of a number of nerve roots at a number of different levels.
Okay, thank you. Question from Petra. For 5 years, she's been suffering from severe chronic SI joint pain after twisting her back, badly misaligned pelvis, which she tried to correct with exercise for SI joint dysfunction. Steroid injection did not work. She's asking, do we do SI joint fusion at the clinic?
In SSC sports medicine, we don't do joint fusion. That would be a surgical procedure. It's not something that I can recall having referred a patient for. Normally, we are able to get enough relief of symptoms through injection therapy and rehabilitation. But by all means, if there are refractory cases, then we may refer them to a surgical colleague for an opinion. So that would be either an orthopaedic surgeon or a neurosurgeon.
Lovely. Okay. How big a factor is ongoing strength and conditioning to prevent a disc bulge, L4 or 5, for long-term prevention?
So long-term prevention, I suppose the key here is trying to keep people moving as naturally and as comfortably as possible. Any strength work is going to reduce the risk of any recurrence of low back pain. Disc bulges will happen regardless of whether or not you do any kind of strengthening program or a preventative program. But if you're stronger and you have better functional movement patterns, then you're much less likely to get symptoms and long-term symptoms from something like a disc bulge. If I can take you back to the slide that I used in the earlier on in my presentation, there's a huge percentage of people out there who have disc bulges and that's not the source of their pain. And quite often that's what we find in patients who come into the clinic. So it's not so much that the strengthening or rehab and exercise programs prevent disc bulge, but they prevent low back pain in general, and they're very, very good at doing that.
Okay, lovely, thank you. A patient's just asking here, he has a pacemaker which is not compatible with MRI. What other scans could be used?
Again, it depends on the diagnosis, or at least the question that you're asking. If you're asking for information in relation to a disc or a nerve root, then we would have a discussion with our radiology colleagues as to whether or not there is an option to work around to get the patient an MRI. There are some MRI centres available that can do MRI for patients with pacemakers. In terms of if the question is not related to a disc or to a nerve root, and it's a bony finding that we're looking for, then a CT scan would be an option. And then thirdly, we have options for X-ray or bone scan, but they would be used much less frequently, and I suppose we get much more detail from our CT scans and our MRI scans. But really it all comes down to what's the question that we're asking. Is it a bone-related problem, or is it a disc and nerve-related problem?
Lovely, thank you. How long will pain relief last from injections, and how many could you have?
So it depends on what the injection is that you're using. Typically, we inject steroid with some local anaesthetic. The local anaesthetic is relatively short-acting. You'll get a few hours of relief symptoms from that, but it'll wear off over the course of the day. The steroid injection builds up over the first few days, and usually you get your most benefit at around about 7 to 14 days. And then we hope for around about 3 months on average. Some patients come to us for a steroid injection of a caudal epidural or a selective nerve root. They'll get one injection, they'll get enough pain relief to allow them to do some form of rehabilitation, and their pain will resolve fully, so they'll never need a repeat. Occasionally we'll have patients who come and get one injection, get a repeat injection 3 months later, and then follow that pathway where they go on to resolution. And then unfortunately there are some cases that are much more resistant to treatment and may need an injection on a kind of repeat 3 to 6 monthly basis. We would usually only inject about once every 3 months, so maximum usually about 4 a year. But we're always reassessing the situation and trying to ascertain, are we doing the injection for the right reason? Is it for the same reason? Have things changed? So there's a lot of thought that goes into the process rather than just looking out 3 monthly injections for the foreseeable future.
Yeah, lovely, thanks. Deirdre says that thanks for this really informative talk. Is there any downside to steroid injections?
Yeah, I mean, there are side effects to any procedure that we do. In general, anytime we use a needle to pierce the skin, there's a risk of creating infection. In the clinic here, we quote 1 in 25,000, and we use a lot of stringent infection control procedures to try and reduce that risk. But that's the biggest concern anytime we do an injection, is introducing infection to the site. From steroid itself, a steroid, about 1 in 100 people can get something called a steroid flare, where their symptoms can get a little bit worse before they get better. Some patients can get pain at the time of injection, which can last for a few days after. Some patients don't get any relief whatsoever, and so they go through the process, they go through the anxiety of getting the injection, and they don't get any relief. But by and large, they are the main side effects. Steroid can also give you some minor side effects, such as facial flushing, which might last 24 to 48 hours. It can also disturb your sleep for 24 to 48 hours, and it can also have an impact on your blood sugars. So if you have diabetes, we always recommend that after a steroid injection, you keep an eye on your blood sugars for a few days.
Lovely, thank you. Just one more then. She had an X-ray which showed a fractured disc, had physio for that. But 10 months later, she's still in a lot of pain. She goes for walks, but very painful when sitting. Any suggestions where she should go next?
It's difficult from the amount of information available there, it's difficult to signpost. I mean, if she feels that she's not getting much benefit, or she's hit almost a roadblock with a physiotherapist, then perhaps it's time to see a sports medicine physician, get another assessment, a second opinion, have a look at what information is there to date, what investigations have been done, and then decide on whether any further investigations need to be done and what other treatment options are available to the patient.
Matt, thanks very much for talking tonight. So we now are going to conclude the evening. There will be more talks in the new year, so when we have those, we will advertise them. Also, you can watch this back through on the website, and all our other talks are on the website as well, or if you can also redirect somebody there as well. We will be sending out an evaluation for tonight as well. That will come out to you tomorrow. Thanks again for joining us, and we'll see you next time.